Hypertension, known as high blood pressure, is one of the most common epidemics in the United States. According to the Centers for Disease Control (CDC), blood pressure is the force of blood pushing against the wall of arteries, which is carrying blood from the heart to the entire body. High blood pressure indicates that the wall of arteries gets thickened, which will slow down the flow of blood circulation. Hypertension is so prevalent that it has become one of the major problems that pregnant women are facing currently. It complicates 5% to 7% pregnancies, and it not only influences the mothers, but it also impacts fetus mortality and morbidity. 2% stillbirth and 10% of all preterm births are caused by hypertensive disorders. Usually, when pregnant women with systolic blood pressure (SPB) over 140 millimeters of mercury and a diastolic blood pressure (DBP) over 90 in two separate tests within 4 to 6 hours, it is considered as hypertension. There are 3 levels of hypertension shown in this table, and pregnant women will be treated with different approaches depending on the level of severity. There are 4 categories in terms of hypertensive disorders: preeclampsia or eclampsia, chronic hypertension, preeclampsia superimposed on chronic hypertension, gestation and gestational hypertension, and I will discuss each of these in a moment. The first one is preeclampsia or eclampsia. It is a hypertension with significant proteinuria induced by pregnancy in the second half of the gestation. It is a major cause of preterm birth and an early marker for future cardiovascular and metabolic disease. If the preeclampsia can be diagnosed in the early period of pregnancy, it can be developed to eclampsia. Eclampsia is a serious condition that puts mother and the baby at risk, and in rare cases cause death. Women with preeclampsia who have seizures are considered to have eclampsia. It is often seen in women who are pregnant for the first time, in pregnant teens, in women over 40, and those with a family history of preeclampsia. If the SPB is over 140, DBP is over 90, and within the 24 hours, if the proteinuria is over 300 mg, then it is diagnosed with mild preeclampsia. In this case, if the fetus is less than 37 weeks, the mothers are encouraged to rest on the bed and lay on their left side until the time of delivery. The reason why to lay on their left side is because sleeping on the left side will increase the amount of blood and nutrients that reach the placenta and the baby. If the fetus is mature, the care provider would suggest to deliver it as soon as possible. If the SPB is in between 160 and 180, DBP is over 110, and within the 24 hours, if the proteinuria is over 5 grams, then they are the symptoms of severe preeclampsia. Similar as in mild situation, if the fetus is mature, it is better for mom to deliver the baby as soon as possible. But if the fetus is less than 37 weeks, the mother may need to use magnesium sulfate or other antihypertensive medication. There is a plausible management which is taking aspirin, but no clinical trials has shown any significant differences between women receiving aspirin and those receiving placebo. In addition, pregnant women should also be aware of HELP syndrome. The name HELP stands for hemolysis, elevated liver enzymes, low platelet count. This is the life-threatening pregnancy complication usually considered to be a variant of preeclampsia. 4% to 12% of pregnant women with severe preeclampsia and eclampsia develop HELLP syndrome. HELLP syndrome is hard to diagnose in the first 6 months because its symptoms are sometimes mistaken for flu and other disease. Most often, the best treatment for women with HELLP syndrome is the delivery of the baby to stop this condition from causing any serious complication for the mom and the baby. During pregnancy, many women who are suffering from HELLP syndrome require a transfusion of some forms of blood product, such as red cells. So, care providers use corticosteroids and other blood pressure medication to manage HELLP syndrome until the baby is delivered. Next one is chronic hypertension. It is a pre-existing hypertension before women get pregnant. This type of hypertension is highly related to the placental eruption, so antihypertensive therapy is required. However, the therapy may harm the fetus. Therefore, experts recommend antihypertensive therapy when the SPB is over 150, DBP is over 100. Having chronic hypertension significantly increases the risk of developing preeclampsia, and this will be talked about in the next slide, which is preeclampsia is superimposed on chronic hypertension. When it is developed when women with chronic hypertension during their pregnancy, after the 20 weeks gestation, if the mother finds a sudden increase in proteinuria up to 300 mg in 24 hours, sudden increase in blood pressure, or sudden decrease in thrombocyte, she is very likely to be diagnosed with this type of hypertension. It is often seen in women with severe chronic hypertension and with pre-existing cardiovascular disease. For women with this type of hypertension in severe situation, they are encouraged to deliver the baby when it is 28 weeks old. If with mild situation, the mothers are encouraged to deliver when it is 37 weeks. Most importantly, preeclampsia superimposed on chronic hypertension requires to monitor periodically and keeping proteinuria, blood pressure, and thrombocyte under control. Gestational hypertension is the fourth type of pregnancy-induced hypertension. It is induced after 20 weeks gestation, and it can be resolved in 3 months postpartum. In most cases, women with gestational hypertension will be developing hypertension in her later life. This is often seen in women who carry multiple babies and whose sisters and mothers had gestational hypertension before. If she has severe gestational hypertension, vasospasm will be developed. This decreases intermittent placental perfusion, causing the IUGR, which is intrauterine growth retardation, oligohegemonians, which is too little amniotic fluid. In this case, baby is not getting enough oxygen, which may cause the ineffective development of its organ and low birth weight. Although all types of pregnancy-induced hypertension may cause severe consequences, as long as they take timely action, those hypertensions are manageable.